in September. So some people have asked me, is my honeymoon finished? I said, I don't know. I guess the first time somebody yells at me, I'll know it's over. But so far, everyone's been very nice. So there we go. So, as stated, I came from Penn, where I worked for the last 18 years, the last 10 of them being vice chair for research there. And I led a center there. And I have up here my old credentials, so you get to see what I used to do before I became system chair at Sinai. I was the director of a center for resuscitation science, which was a multidisciplinary cardiac arrest research center, which had folks from neurocritical care, pulmonary critical care, emergency medicine. It was really a lot of fun. And I'm essentially hoping over the next year to build a similar structure here. Because I really, really believe in collaboration. It's near and dear to my heart, and especially collaboration with critical care. I spent much of my research time up in the ICUs at Penn, so I like to say I'm not a critical care doctor, but I play one on TV. I sort of I think had EM critical care been a thing 15 or 20 years ago, I totally would have done it. All right, with that little prelude, let's launch in, and we're going to basically cover two areas today. About two-thirds of this talk is going to be around temperature management and to try to help explain some of the controversies there. I know some of you know this area is controversial as far as how it's applied. So we'll go through some of the data and hopefully make some sense of it. And then the final one-third, we'll talk about an exciting new area for cardiac arrest post-arrest care, which is the use of ECMO, which in the CPR world is known as eCPR. And I know there's growing interest here in ECMO, so I thought that would be a topic worth some conversation. So to start us off, and I know this is, of course, review for this erudite audience of mine, but just to get us on the same page, when I talk about cardiac arrest, and when resuscitation scientists talk about cardiac arrest, we're not so much talking about the phenotype of in-hospital arrest of folks who are clearly dwindling down, increasing pressors near the end of life. The reason why I make that distinction is there's often a lot of nihilism around in-hospital cardiac arrest, and perhaps correctly so. There are many people who are clearly just moribund and dying. When we talk about cardiac arrest care and the folks that make us passionate about this work, it's people whose hearts are beating normally like this, and then they go into a sudden arrhythmia like this, ventricular fibrillation, and a cardiac output drops to zero. So in other words, abrupt, sudden, potentially correctable physiology, either arrhythmic in origin or ischemic in origin or from pulmonary embolism. So some specific acute insult that causes sudden loss of cardiac output. And as you all know, cardiac arrest is a very special disease in that it's uniformly fatal. It has a 100% case fatality rate unless something is done about it. So there are no natural history survivors of cardiac arrest, which makes it a very interesting disease from a critical care and emergency medicine perspective because we thrive on critical, time-sensitive life or death situations. And this is the ultimate example of that. Just a little bit on the epidemiology, it's a very big public health problem. Over 350,000 people suffer cardiac arrest each year in the United States, so that's 1,000 a day, essentially. And when we look epidemiologically at out-of-hospital cardiac arrest, it's actually not people who are elderly and infirm like you might think. Statistically, it's people in their 50s and 60s and generally in good health. So these are the people who are going to work, who are, potentially on an ICCM critical care grand rounds in their 50s or 60s, and they have a sudden event. And I show you here some newer and older celebrities who have suffered cardiac arrest in recent years. I won't ask you to name them. Some of these pictures will give away my age, but there you have it. And it also is both gender and race blind, in that people of both genders get it, people of any race gets it, of any socioeconomics. It's an equal opportunity killer. Now, cardiac arrest had a moment in the sun a couple of years ago with the collapse of this gentleman. This is Damar Hamlin. He was a Buffalo Bills player, and he had arguably the most watched cardiac arrest in the history of cardiac arrest because he had it during an NFL playoff game in primetime television. And millions of people saw him collapse, saw a resuscitation, saw CPR, and he has made a full neurologic recovery. And indeed, he's playing as we speak on the Bills this season in the playoffs. So it's a remarkable story. And this caused a big spike in interest in cardiac arrest, CPR, and related things. And I'll tell you that he also got targeted temperature management at the hospital he went to and has had a full neurologic recovery. Of course, was it from that? Was it just from the excellent response? We'll never know. But he's a nice poster child for someone who has a cardiac arrest and makes a full recovery. And that's important because we need to combat this narrative of nihilism. There are survivors of cardiac arrest who can do very well and thrive. More locally at Penn, we've had certainly many survivors, and we sort of follow them as alumni of our programs. And this is an example. He's been public, so I can say his name, Zach Conrad. He had an arrhythmic event from undiagnosed long QT syndrome in his 20s. Got CPR, cath, ICD, cooled, the whole 9 yards. And he made a full recovery. He's now a father of three. And we did a radio piece for NPR. That QR code, I think, is still active if you'd like to listen to a 10-minute piece on cardiac arrest and post-arrest care. It's sort of a nice listen. And then we talked to him, his wife, nurses, doctors. It's a nice sort of 360 story. But now let's make a segue into the science of this whole thing. So there's been this concept, a prevailing concept for maybe 3 or 4 decades now, that maybe, just maybe, if we cool people after cardiac arrest, we can improve their outcome. And this was studied in the 60s, 70s, and 80s in the animal lab. And there's a huge animal literature on this with cardiac arrest models showing very strong evidence that TTM improves survival for animals. TTM, targeted temperature management, used to be called, by the way, TH, or therapeutic hypothermia. You'll still see that term in the literature. A little confusing that there's two terms. I'll get to why later. But TTM, so there's a strong literature from the animal lab showing that there's a dose effect relationship with cooling. That is to say, animals in cardiac arrest, the longer you cool them and the deeper you cool them, the better the outcomes, the better the survival. And so this then went to humans, and I'll share with you some of those trials. And the prevailing human paradigm for this, before the last 5 to 10 years anyway, was that people were cooled, kept cool for a period of time, and then rewarmed. And this usually started in the emergency department, then continued up in the ICU. So this was a ED to ICU therapy. And the idea here is that by cooling, you mitigate many of the pathophysiologic processes that kick in with ischemia, reperfusion, injury. And I could go through in great detail the mechanisms. It's been sort of well studied in the animal world, but I really wanted this to be a more clinically oriented talk. So suffice it to say, there's very good data on its effect on mitochondrial function, apoptosis, cytokines, all sorts of things. Now, where did this come from clinically? Well, if you wanted to know about the foundational trials that even made this a conversation for clinicians, it's because of a number of trials that came out about 20 plus years ago that randomized patients to cooling or no cooling after cardiac arrest resuscitation. So these were out of hospital arrests. They got their pulse back, and then they were randomized to cooling. And by cooling, the animal literature showed that the therapeutic target of 33 Celsius seemed to be optimizing both outcome and minimizing side effects. So that's what was chosen. So 33 Celsius is a target temperature, and these trials looked at them mostly in ventricular fibrillation patients. And to show you what the data look like from one of these trials, this is the HACA trial from 2002, done in Austria. You see two temperature curves. There is a higher curve, that is the control group, or quote unquote normothermia group, and then a cooling group. And the cooling group was cooled to 33, they were kept cool, and then they were rewarmed. And outcome was evaluated between these two groups. Well, I line up these three older trials to show you their summaries, and you can just look at the red percentages if you like. All three trials were smart enough to only count as success with neurologic recovery. I think we would all agree the goal of cardiac arrest care is not to send people to the LTAC, trached and vented, and neurologically devastated. That's not a success. So they only count in the red percentages here if they had a CPC 1 or 2, cerebral performance category of 1 or 2, which, as you all know, means sort of walking and talking and generally functional. And so you can see in all three trials a marked improvement in survival when patients were cooled, when they received targeted temperature management. These were different study groups, different countries, slightly different protocols. So this was considered a robust result. Now, one question was, is this a transient benefit or durable? And the HACA study looked 6 months later and found that everybody, all but one patient, were alive and doing well at 6 months. And indeed, many studies have come up subsequently showing if patients survive to discharge with a CPC 1 or 2, they can do very well. Our longest survivor from Penn I talk to once a year, and they're 18 years out from their cardiac arrest event. So if you leave the hospital walking and talking and generally good function, you can do very well. Well, I should back up for a sec. These studies looked at VFib, VTAC patients. And the earlier debate, before perhaps some of your time, back in the early 2000s, the earlier debate was, well, we have strong RCT data showing TTM works for shockable rhythms. What about PEA resystole? And there's a debate whether we should cool them. Now, I always felt it should be the same in that the main injury here is the brain. This is really a brain, post-arrest care is a brain issue by and large. The heart is also at issue sometimes. But the point is, the brain cares that there's blood or no blood going up the carotids and the vertebral arteries. I always hypothesized the brain shouldn't care what the exact rhythm of the heart is. It just cares that there's no blood being supplied. And indeed, this was borne out by a study done in France in 2019, where finally it took this long to do it. They enrolled people with PA and asystole. So they tried to put to bed the question of whether this was rhythm agnostic or not. And what they found was, and here are their temperature curves, they did 33 versus 37. This is known as the Hyperion trial. It's a good study to look at. They found that there was a significant improvement in neurologic survival when patients were cooled. So this is one more piece of evidence saying you cool to 33, you have better outcomes. Now, interestingly, the overall mortality was the same in both groups, but neurologic survival was better with cooling. And this actually is consistent with other work showing that many people are just so devastated after cardiac arrest. Maybe they had a long downtime, maybe they didn't have bystander CPR. Cooling is not going to save you. But for those who are on the bubble, for those who might survive, you will survive better. You'll survive with more brain function. And that's really a great sort of story to tell. And this was the story that informed the HA guidelines. So as many of you know, the American Heart Association updates resuscitation guidelines every 5 years. They also offer interim updates, but it gets a little confusing. But every 5 years, there's a basic package of updates of resuscitation guidelines. And in both 2015 and 2020, of course, we're awaiting the 2025 update, the use of targeted temperature management was recommended following cardiac arrest. And they did it for any rhythm. And indeed, they even suggested you should think about it for both out of hospital and in hospital arrest. The data for in hospital arrest is very poor, so we don't really know. But they said, look, we're not saying you have to do it, but you really should think about it for any patient that you resuscitate after cardiac arrest who is not waking up. Obviously, someone who wakes up right after an AED shock does not need to be cooled, but if folks are neurologically injured or appear to be so immediately after arrest, they warrant consideration for TTM. Now, they don't say 33 necessarily in their guidelines. They actually give a range of 32 to 36. And you might wonder where the higher temperature comes from. And this has caused some confusion. And this is the transition now to the current controversy in TTM, which is what is the goal temperature? And do we need to cool or just do normothermia? And I'll explain what I mean by those questions. So in 2013, a Scandinavian group asked the following question. Do we really need to cool to 33? Or is fever avoidance the most important part of this whole thing? And so they randomized patients at 33 versus 36 for 24 hours after cardiac arrest. Now, why is this an issue? Well, what we know, I'll tell you what we know. What we know is that up to half of patients after cardiac arrest get fevers. They're neurogenic fevers caused from brainstem dysfunction. If you do nothing with a post-arrest patient, they may very well get a fever. We also know, point number 2, these fevers are bad for the brain. It is very well established, and I don't know if we have neurocritical care folks on the call, but it's very well established in the neurocritical care literature that a devastating brain injury does worse with fever. Notice I didn't say cardiac arrest. This goes for severe stroke. This goes for bad subarachnoid. This goes for severe brain trauma and diffuse axonal injury, and it goes for post-arrest injury as well. The very injured brain does not like fever. Fever is bad for the brain. So when you combine the fact that fever is common post-arrest and fever is bad for the brain, they said, well, for sure we want to avoid fever. We all agree with that. But maybe that's where the benefit is. Maybe it's not actually cooling to 33. Maybe it's just very, very scrupulous fever avoidance in these patients. That counts. And they enrolled patients in this study. Now, here's where it gets interesting. And this is, I think, going to be one of the key talking points I'm going to make, which is that we should all be very careful to not overinterpret trials. So this was done in Scandinavia. And in Scandinavia, they have very different EMS protocols than the US. They have something called a stay and play protocol. In the US, largely a scoop and run. And I'll explain what I mean. Patients in many European systems will only be transported if they get ROSC in the field. So they transport people with a pulse. They will not transport you. They will call you dead in the field if they don't get you back. In the US, New York, Philadelphia, many places, they'll transport an active CPR. So the kinds of patients we receive are very different phenotypically. This explains the following data. In their in their study, the bystander CPR rate was 73%, very, very high bystander CPR rate. The rate of shock was very low. I don't know about the prevalence of shock in post-arrest patients yet at Sinai. I'm too new here to really dig into the data, but in most major US centers, about 30 to 40% of post-arrest patients have shock. Also, the average post-arrest lactate at Penn was 12. In this study, it was 6. I don't know, as at Sinai. And also importantly, 40% STEMI rate. I know that the STEMI rate in the US for post-arrest is 5 to 10%. So this is a different population than what we see. So I always tell people you really, really got to pay attention to what I call table one. It's often not table one, but metaphorically it's table one. Who got enrolled in the study and does it apply to my patients? And this was done in Scandinavia with very different patients than what we see, for example, in the Sinai ER. Well, despite that caveat, it's important to say what they found was no difference in outcome, whether you cooled to 33 or managed patients at 36. Well, this was a big deal at the time because for a decade or more, everyone felt that 33 was the law of the land, and now all of a sudden this sort of blew that up. So now clinicians were left confused. Do we manage at 33? Do we just do 36? Now, it's important to note the study did not show that 33 was worse. 33 did not hurt anybody. Survival was the same in 33 or 36. So at the very least, you now have two options. But how do you know what to pick? Well, if that, I'm going to skip this next thing. If that wasn't confusing enough, the Scandinavian group then went on to publish a newer study, and this was published 2 years ago now. I forgot to put the date. Sorry about that. 2020, or maybe 2021. Sorry about that. 3 years ago. This study randomized patients now to 33 versus true normothermia, or 37.8 is what they chose. So they were emboldened by finding that 33 and 36 gave the same results. So they said, okay, 36 you could argue is like mini hypothermia, right? 37 is normal body temperature, I suppose, although obviously that depends on the individual. So in this protocol, they enrolled people to be randomized either at 33 or a pragmatic control group where clinicians were told you got to keep the patient under 37.8. Now you can do this either passively, or if they spike a fever, you have to use a cooling device. And I'll tell you that consistent with what I mentioned earlier and consistent with prior data, almost half the patients in the control group ended up on a cooling device. So the important lesson here, and this is, I think, one of the most important take-home points, if you choose to not do 33, there are clinical reasons why you might not do that. But many people have misinterpreted the science and these RCTs to say we don't need to do anything. And what you will find if you do not do any temperature management in a post-arrest patient, many will get fevers and you're going to get yourself into trouble. And you'll also make your nurses upset because at 3 a.m, they'll be calling you about a person who's now spiking to 38.7 and they want you to do something and you're behind the curve and causing brain injury. Well, anyway, in this study where they compared 33 versus 37.8, again, hard to know whether this is a generalizable population. An 80% bystander CPR rate, I mean, just crazy. I'm sure New York is not 80% in the post-arrest population. And a very similar rate, high rate of PCI. 38% of patients ended up getting cath and PCI. They again found no difference in survival. But in both TTM 1 and 2, it's this very select, highly cardiac-oriented population that all had very little shock and high bystander CPR rates. So the question is, what do we do with this? My thesis that I will present to you today, and it has been my thesis for quite some time, is that we have to be very careful not to throw out the baby with the bathwater here. Or to say it another way, there's been this huge move towards abandoning TTM, which I think is not correct. For sure, at the very least, we need to do normothermia. That's what the studies show. I mean, that's cleaving to the RCTs. But given the strength of the literature on TTM to 33, I think we have to be more selective. And the problem with these trials is there was no stratification for injury severity. And indeed, there was no criteria for enrollment based on severity either. So I worry there are patients within the cohort, the universe of cardiac arrest patients who would do better at 33. And I will now support that hypothesis, that argument with studies. So, and this is the menu for the next set of slides. So first, I'd mentioned earlier that there's a massive animal literature around dose effect of TTM and outcome. I only show you 3 examples. I could show you literally 100, but there are studies in rats and dogs and pigs and cells. I ran a mouse lab at Penn and we showed this in mice that when you cool earlier, longer, and deeper, the animals do better. And because it's animals, you can do mechanistic studies. You can look at mitochondria, you can look at brain histology, and you can really get at why TTM works. And this has all been documented fairly extensively. So there's good mechanistic biologic evidence of reduced injury based on the dose of TTM. So that's interesting. And that would support cooling deeper. But then again, cancer has been cured in a million mouse studies and doesn't apply to humans always. So it's not enough. But it's the first chapter of my argument. The second chapter is a more philosophic one. When you're treating a patient or treating an individual, and you have to make a decision for that individual. Well, here are the three biggest, I left off one of the studies, the three biggest studies, all showing a benefit of cooling. There are two studies, the two studies from Scandinavia that I showed you, that are neutral. They do not show worse outcomes with cooling, they are neutral. There are no studies that show worse outcomes with cooling to 33. So now you're faced in the ICU with a patient who arrives from the ED who's pretty neurologically impaired, initial lactate 14, didn't get bystander CPR, and their family is saying, "Doctor, do everything you can for my loved one." And you know this patient has a very high probability of a bad outcome and severe brain injury based on lactate and shock and long downtime and all the criteria that you know. You know there's some evidence showing that cooling to 33 works. There is no evidence showing that cooling to 33 hurts, and there's two studies that are neutral. The current vibe, for lack of a better term, in the United States is to not offer TTM, but we know there's some evidence that it helps and there's no evidence that it hurts. So philosophically, this troubles me a little bit. My wife's a cancer doc, and she says this is a ridiculous state of affairs because in the cancer world, people come to her all the time with stage 4 cancer. They're desperate. They say, "Do everything you can, doc." And she said, "Well, I have this drug. Studies have shown that it won't kill you. But the evidence is a little bit mixed on its benefits. Some studies show it benefits you." And she says 100% of people sign up for the drug. If you know you're at the end of the rope and there's a therapy that might work, but the doctor is convinced it will not hurt you, people want the therapy. And yet, we're often not offering this therapy to patients who we know will be devastated. So that's sort of a philosophic argument since there's no evidence of harm. But I think the more telling experience or evidence is from real world experience. There have been a number of studies now published where hospitals have been brave enough to air their dirty laundry, where they went to 36 after that first Scandinavian study, which, by the way, is known as the TTM1 study, the second one, TTM2 study. After TTM1, they switched to 36 and they published their outcomes. And this is from Melbourne, Australia. And they found that when they changed their hospital protocol 36, survival worsened and they switched back to 33. So they harmed people by abandoning 33. If you like US data, this is from Harborview Hospital in Seattle, same thing. They switched to 36 and survival worsened. It dropped from 40% to 30%, essentially, and they went back. So the real world experience is a cautionary tale. You know, there's always this gap between RCTs and real world experience, and there's a variety of reasons for this. But one of them is that RCTs are not real world conditions. There's study coordinators, there's protocols. Patients fall out based on protocol violations. In the real world, of course, it's a lot more variable. And sometimes you see different things. And it turns out in these studies, and there are two others like it, and they had the same results, when switching to 36 outcomes worsen. So that's a cautionary tale. But I think the most important evidence we have on this topic to address my hypothesis, and this will, I think, ring very true to the critical care mindset and ethic, is that it depends on the illness severity. And in cardiac arrest research, we are guilty as charged. We're very crude. We just say you either got your pulse back or you didn't, and we enroll you. And in critical care, you would never do this. You know the sepsis literature. It's a very confusing literature, and it really, really depends on how septic you are, essentially. You have to stratify by injury. And so this is the first serious attempt to do so. I love this paper. Pittsburgh gets a lot of post-arrest patients like Penn does, and they have a scale that they developed called the Pittsburgh Cardiac Arrest Category. Essentially, it's an injury severity scale. Nobody really uses it. Clinically, it's not been super well validated, but it's useful, and they used it for their research purposes, where they looked at survival at 33 or 36 in their system based on the severity of illness. And lo and behold, what they found was the sicker patients who showed more neurologic impairment, more shock, did better if they were cooled to 33. The patients who were less injured did better if they were managed at 36. So I like this study because this study, in my mind, is the way forward. It unifies the entire literature. It's not that 33 is right. It's not that 36 is right. It's that it depends. It depends on the patient. And we have to be a lot more sophisticated and tailored in who we care for. Now, what criteria should we pick 33 or 36? We could use their Pittsburgh cardiac arrest categories. We could use other scales. Unfortunately, it's not well established. But what I would suggest is that 33 may benefit some people. And if we abandon TTM and abandon 33 altogether, we may be doing some patients a disservice. If you want additional studies that support the same point, this is a Japanese study. They used a totally different scoring system called RCAST, and I won't bore you with the details. It's bystander CPR, it's initial lactate, but in any case, they found that the same thing. If you were very, very sick, it didn't matter so much. Most people died. If you weren't very sick, it didn't matter what temperature you picked. Most people did pretty well. But they found there was this group of moderately injured people who did much better when they were managed at 33. If you need a third example, this is actually, in a way, my favorite because this has real physiologic endpoints, not scoring systems. This is out of the Netherlands, and they looked at EEG, and they categorized people's EEG, mild, moderate, or severe injury. And you can see in the graphic here with the red and the green, if you had severe encephalopathy on EEG, it didn't matter if you cooled to 33, 36, didn't cool at all, people did poorly. If people had a very healthy looking EEG, it didn't matter so much either because people did pretty well. Although there was a trend towards better outcome in 33. But in the moderate encephalopathy, there was a clear difference, and they did better at 33 versus 36. So we now have 3 studies showing the same thing, that some people do better at 33, other people it doesn't matter. And that, I think, is probably the truth in the thing. And now to give an analogy that is near and dear to your heart. You're now in the ICU, and a medical student approaches you. And they say, I've been reading up on sepsis, and I have a question, guys. Should we give vasopressors for sepsis? In a way, it's a good question, but in a way, it's a bad question. You might politely smile to the student and say, look, a great topic, vasopressors for sepsis, but you're sort of framing the question wrong. It's not should we give pressors or not for sepsis. It's for which patients should we give pressors? That's a more sophisticated question and a better conversation. Because as you all know, some patients who are in sort of earlier stage of sepsis, if you will, do very well with fluids and antibiotics, and they never need pressors. Some patients absolutely need pressors. So I think that's well understood in critical care. It's poorly understood in the world of post-arrest care management. And that's where we need to go. Now, dose isn't just the depth of the temperature, it's also the duration. And one study has looked at 24 versus 48 hours of cooling for cardiac arrest. And the reason why most protocols around the country still are at 24 hours is this was a negative study. Here's the results. The mortality was indistinguishable between 24 and 48 hours. However, there's a trend towards better outcome with longer cooling. This is consistent with animal literature where there are a number of studies showing that longer cooling has better results if you're a rat or a pig. And so where does this leave us? Well, there's actually, I was just going to make the point. There's a large US study underway right now through a trials network called Siren. Siren is an emergency care network, NIH sponsored. And I was a site PI for Siren at Penn. We are about to start, one of our faculty, Ethan Abbott, is going to be the site PI here. We're enrolling people in a duration trial. So hopefully we will see if the study was just underpowered and we need a much larger sample size. Well, I now want to make a further point about this fever thing. You know, I mentioned earlier that following cardiac arrest, many people get fever. Well, both our group and the Pittsburgh group simultaneously looked at this and found that even after TTM, people spike fevers. So this neurogenic fever, this brainstem dysfunction lasts for days. And so the model here is patients were cooled and rewarmed following standard protocol. And then, you know, the pads were taken off and everyone says, yay, we did a good thing. But even then, a whole bunch of people spiked fevers. We call this rebound pyrexia because they were cooled, rewarmed, and then boom, they got fevers. And if you looked above and below median, it made a real difference with outcome. And we tried to quantify this. And in another study done by a PhD student of mine, Ann Grosser, who's now faculty at Harvard, we looked at the maximal temperature and the probability of good outcome. And there's a real dose effect. So this is not surprising news. This is consistent with the neurocritical care literature. The higher the temperature, the worse the outcome. So we really, really, really want to avoid fevers after cardiac arrest, and there's strong evidence for why we should do so. So the thing is, clinical teams say, yeah, sure, this sounds great and all, but 33 has side effects, right? And so I think part of this is an education thing to recognize that for select people who are more injured, that we might want to cool to 33, which is certainly still consistent with the HA guidelines, the side effects are actually very manageable. So, for example, the most common side effect of cooling to 33 is bradycardia. Bradycardia is really not a big deal. It's super common following cardiac arrest when you cool people. It may actually be protective. After all, we like low heart rates to preserve myocardial oxygenation. So this may not be such a bad thing, but at the very least, it's usually not of hemodynamic consequence. Now, the other concern we have sometimes is bleeding. When you cool patients to 33, there is a modestly increased risk of bleeding. People become a little coagulopathic, but all the studies show that clinically relevant bleeding is less than 1 in 20 patients who get cooled to 33. So it's not super common. And no study has shown increased mortality from cooling to 33 from bleeding. It's pretty minimal. So usually the clinically relevant bleeding in these studies is categorized as any oozing. So, oozing at a central line site or the Foley turning pink. So in other words, clinically, you can mark it down as they're bleeding somewhere, but that's it, and is usually easily managed. And then all the other things we think might be an issue, infection with cooling or shivering, these are all the same when you look at 33 versus non-33 groups. So they're really not significant side effects. And so walk through these bradycardia, we often see heart rates when we cool to 33 down to the 30s to 40s. Younger residents will often reach for the atropine, and I say, whoa, slow it down, buddy. Because after all, appropriate critical care evaluation is not to treat the number, say, what's the mean arterial pressure, what's the urine output, what's the clinical exam, before we jump for the atropine or the pacing pads. And you'll find that many patients tolerate these low heart rates post-arrest perfectly well. So no treatment is usually needed. If people are having hemodynamic consequences, you can always titrate up from that temperature. So what about the coagulopathy issue? Well, what many sites do and what we did at Penn was we had a very simple sort of algorithm. Now, it's important to note this is not based on any RCT, so this is not evidence-based. This is just clinical gestalt-based because there's nothing better than that right now for the question of coagulopathic management. But we found experientially that if someone had a history of a GI bleed, they were on a heparin drip, they were on a NOAC or Coumadin, the bleeding risk was not higher at 33. It really didn't matter. If they had an active GI bleed or they had blood in the head on head CT, we did not want to cool them because the risk benefit individual profile for that patient was worse. So we basically had a quick little bifurcation moment in the ER saying, well, if they're not actively bleeding and they don't have blood in their head, we'll do 33. If they regardless whether on their heparin or they had a recent surgery or whatever. But we would do 36 or normothermia for those, either clinician discretion, but if specifically for the coagulopathy issue, we would not have it as a contraindication for TTM. We would just do 36 or 37 if they had a GI bleed or intracranial bleed. Okay, so that was, as promised, the first 2/3 of the talk. The final third, I want to cover an interesting, relatively new area in cardiac arrest and post-arrest care, which is very exciting and still very much evolving. So this is really more of a science than a clinical recommendations kind of part of my talk. But the question of using ECMO during cardiac arrest and then immediate post-arrest care. Of course, it's hard to know when you're actually post-arrest if you're on an ECMO circuit, or technically you're still in arrest, but you're sort of alive, right? The definitions get a little funny. But in any case, when you institute ECMO during cardiac arrest, we call that eCPR. That's the term that sort of evolved. It's ECMO CPR, essentially, extracorporeal CPR. The leader in this subfield of resuscitation science is very much this guy named Dimitris Yiannopoulos. He's in Minnesota, and he has really pushed this concept that we can put people on ECMO as a bridge to definitive care. For example, refractory VFib in a 55-year-old hypertensive who collapsed at home is more often than not an LAD occlusion. And if you can't get them back and they fail shocks, they fail amio, what they really need is a cath, but you can't cath them if they're dead. So you can put them on an ECMO circuit, get them to the cath lab and open up their artery. And he's done this a number of times, and I'll show you one of his trials. This is an earlier proof of concept study when he sort of started doing this work. And by the way, I should be clear on our definitions for those of you who are not as familiar with ECMO. I suspect most of this group is very familiar, but there's VA ECMO and VV ECMO. When we're talking about cardiac arrest, we're generally talking about VA ECMO. So eCPR is VA ECMO because, of course, the heart is the lesion here, and therefore we need to bypass it. And so how do we do VA ECMO and cardiac arrest? Well, believe it or not, it is being done in the field in some select places. And this is in Paris. In Paris, they have a whole system and they've published on it on how to do ECMO in the field. I do not think, my personal humble opinion, I hope I don't offend anyone here, I don't think New York City is quite ready for ECMO in the field, although I know there's discussions actively at Sinai about working with EMS to direct patients to ECMO centers, which I think is a very good topic of conversation. I would love to see ECMO in the field in New York, but I think we have bigger fish to fry before we go there, is my personal opinion. I'm happy to broker disagreement on that point. But here is one of my most beloved pictures amongst resuscitation geeks like myself. This is in the Louvre Museum in Paris, and this is a patient being put on ECMO in the middle of an art museum, which is just fantastic. And so in Paris, they're very aggressive about this, and they've had a long experience now, almost 6 or 7 years running, and they sort of believe in it. In other cities that are very advanced in this, Taipei, Taiwan is doing this, and Minneapolis is doing this. Houston has started this. So there are some places that are beginning to be early adopters of this therapy. Now, um, oh, by the way, also New Mexico, Albuquerque, New Mexico. So how might this be done? Well, in the places in the US that are doing this in the field, you have to have sort of a special resuscitation unit. So there's real cost involved here. So here is a large ambulance in New Mexico that's set up as a mobile ECMO, a mobile device, a mobile center, if you will. Minnesota, they have the same thing. They have a mobile ECMO unit that drives around and puts people on ECMO on the floor of their house. It's wild and crazy. And of course, you have to have very careful criteria for this. So if Dimitris Yiannopoulos were in the room right now, he'd say, before anyone runs crazily into some wild ECMO adventure, patient selection is the most crucial thing for ECMO programs. You got to pick the right people. Because if you're overzealous and you pick any old person who didn't get bystander CPR and it was asystole, you're just going to have a mess on your hands because survival will be terrible. And you're going to have all these people on circuits that have the ethical problem of turning them off. So you need to be judicious in who you pick and in how you train. But nonetheless, that caveat aside, there are some strong data for this. And so this is a study published in The Lancet, the arrest trial from Dimitris and his group. And they actually had to stop the study early for ethical reasons because they had such high survival in the ECMO group in Minneapolis that they could not randomize people to no ECMO anymore. So this is now the standard of care in Minnesota. The standard of care in the field, and it's in their EMS protocols in Minnesota, is if you collapse and you have a witnessed arrest, bystander CPR, and refractory VFib, you will get mobile ECMO. They will dispatch a mobile ECMO unit and you will get it. It's crazy. So in some places they're doing this. And this is a picture of my friend Dimitris. He's a very ambitious interventional cardiologist, great guy, full of energy, very much a preacher for this therapy. And there's a whole New York Times article on the race to reinvent CPR. Now, I do not believe personally, a little bit different than Dimitris, that this is going to solve all of our problems. It's very expensive. There's a lot of training involved. The team has to be right. The patient selection has to be right. The community has to be primed for this. So I think there's a lot between here and there. So I'm not quite with the New York Times article here, but I do think it's an exciting area that I want to make sure you're aware of because I think you're going to be hearing more and more of this at critical care conferences and various meetings you will go to. But there's a lot of work to be figured out. So, where should we do it? Should this be done in the ICU, in helicopters, in the field? And do we have the right devices? Can they be optimized, et cetera, et cetera? There's a lot of research work to be done. And I think this is going to be a very fertile area for funding in coming years. Now, I wanted to end with a patient story, and some of you may recognize this guy. This is his stage name is Glaucom Flecken. He's a TikTok, Instagram superstar, and he's a doctor. He's an ophthalmologist. His real name, which he's willing to share, is Will Flannery. Will Flannery is an ophthalmologist in Portland, Oregon, but he's made quite a name for himself with millions of followers. He does medical comedy. If you don't know him, you should definitely check his stuff out online. If you Google Glaucom Flecken, you will find a million things. It'll light up like a Christmas tree. He's very funny. And he has some critical care doctor skits in there as well. He plays different doctors. Anyway, he had a cardiac arrest a few years ago and made a full recovery. His wife, pictured here, did the CPR on him. She is not medical. She didn't know how to do CPR, but it was a telemedically guided CPR where the dispatcher coached her on the phone on how to do CPR, and he's made a full recovery. And they've actually sort of turned this into a shtick, if you will, called Wife and Death. That's their comedy show, Wife and Death, like Life and Death, get it? And Wife and Death, they talk about their experience. And of course, it's sort of funny and lighthearted, but it's also at times very serious. And they talk about what it is to be a cardiac arrest survivor, what it is to do CPR, what it is to be in an ICU, post arrest, et cetera, et cetera. And they do these keynotes at various conferences. I am sure they have or will be keynotes at critical care conferences that you will attend in coming years. They're really fantastic, and they have a lot of content online as well. All right, so with that, I wanted to leave about 10 or 15 minutes for conversation because I'd love to hear your thoughts on these topics. I just want to acknowledge a number of the staff members and residents and others who are involved in some of this work at Penn. That is my team at a CPR training event in Philadelphia. I am a big believer in community training for CPR because despite all this fancy talk of ECMO and cooling and all this stuff, there's nothing like good old bystander CPR. It's got the biggest effect size of any therapy in the cardiac arrest business. And the more people we train in CPR, the better, the easier our jobs will be in the ED and ICU. Okay, I will stop sharing my screen. Thanks for your time, and I'd like to see if folks have any questions for me.
Hey Ben, thank you so much. That was an amazing talk. Can you just talk a little bit more about um, the ice cap trial and where you see that going since we're going to launch it and Neha's on and we'll be happy if you do.
Oh, yeah, sorry. I mentioned Ethan. I forgot to mention your name as well as Ethan's co-pilot on this. I apologize. See, here I am as a chair just promoting my own faculty selfishly. I'm a bad, you should scold me for that later. Yeah, so I'd mentioned the word siren. What I didn't mention is the word ice cap. So siren is the trial's network. Ice cap is the trial. So the ICECAP trial is a randomized adaptive trial of different durations of cooling after cardiac arrest resuscitation. So these are out of hospital patients. They come in through the ED, they've gotten ROSC at some point, and they get randomized to different
I
cooling
look at that
durations.
now. Look at the
Um,
ABG.
oh, I
How do
think
I now?
someone's
I
off.
won't
Someone's
do it because she's overloaded, but I guess I'll
Oh, we're hearing a clinical conversation. I don't know if Umesh, if you can hear us, maybe you want to mute that, or someone can mute her. Anyway, right. Oh, I'll just have to talk over for a little bit. The ICECAP trial. So it's a tough trial, by the way. And Nan and Ethan are very brave to be plunging into this. Having been the site PI for 3 years for this trial at Penn, let me tell you, it was a labor of love. There are a number of criteria that have to be met. It's very challenging. Cardiac arrests, of course, are unannounced and a time-sensitive response. So this is sort of a 24/7 business. So now I hope you know what you're getting yourself into here. It's a tough enrollment paradigm. Suffice it to say that the trial will be going on for a couple more years. It's a slow enrolling trial. In my humble opinion, the design isn't quite right. One of the toughest criteria is you have to get family consent. This should have been an EFIC trial. Don't get me started. I'm going to trigger myself here. I'm going to pull back from the ledge. It should have been an EFIC trial. Instead, it was a consent trial. And you have to consent family within 6 hours of arrest. Now, you guys know this. When patients arrive in the ICU, first off, you got to find the darn family. When the family shows up, they're in no mood to talk about research, right? You've seen this. They show up in the ICU and they're sepsis, cardiac arrest, you name it. They're upset. They don't know what's going on. It's their first time having a critical care experience for many of them. The world is bewildering. They see machines beeping, they see drips, they don't know what's going on. In cardiac arrest, many of these patients were perfectly fine the day before. So their world has utterly changed in a heartbeat. And now, Cornea and Ethan are going to approach people and be like, really sorry for your situation. By the way, I've got a study for you. Well, what you will find, if Sign is anything like Penn, is that you get a lot of skepticism and a lot of refusals. And it's not even outright refusal. What families say in their mind, very appropriate, is, Doc, I need a day to think about this. I like this is a lot. I just can we talk tomorrow about this trial? If they're being polite and they don't tell you to get out of the room. And then Neha and Ethan are going to say, well, see about that. We have to make a decision within the next 4 hours because we have 6 hours from Roskin. We're 2 hours in, so you got to decide. It's actually 6 hours from device, sorry. My point being, it's a tough sell. And in my mind, a little bit even unethical of a sell. I feel it's not a nice thing to do to patients' families to make them in this decision mode within 6 hours of the most catastrophic event of their loved one's life. This is why EFIC exists, by the way. Those of you who don't know, EFIC, Emergency Exception from Informed Consent, it's a well-established mechanism by the NIH and FDA to do trials without consent. If you can justify that they are a time-sensitive, critical trial that could not be effectively done without EFIC. And I think this trial would have qualified. But again, I was on the protocol design committee. There you have it. So the ICECAP trial. Sorry, I did give you more of a speech there than you wanted. It's going to be starting soon here. And yeah, and we're going to have to stay tuned. It will enroll from the ED. So this will all be, or I should say the therapy will be started in the ED. Some of the consents will be in the ED, some in the ICU. I suspect, given our boarding problems, most of the consents will be ED based because I don't see a lot of these patients zipping up to the ICU within an hour or two, but what do I know? So that's the ICECAP trial. Just for people who are interested, the PIs of the ICECAP trial are at Michigan, Will Maher and Rob Silbergleit. They're both emergency docs at Michigan. Both good, smart people, but I feel like, this was a large committee on the protocol, and sometimes big committees generate bad work. It's death by committee. So there you have it. But I'll stop there before I make enemies amongst the siren community. They're all my friends, by the way. And I've said this to them, so it's not like,
No, and I think what you expressed is actually what we were worried about when we first signed up for the trial as well. First, just even getting anyone cool to that temperature within the time frame is not that easy either.
You're correct.
But thank you for your talk, because I know amongst ourselves we have a lot of debates about 33 versus 36, and I think that's the other part of ICECAP is convincing, as you can see, a very large group of intensivists that 33 is also required. For the trial, obviously 33 to 34 is required, but is something that we need to aim for, because a lot of our units have gone to just cooling or TTM to 36 now. So I think that's going to be our next step is kind of getting a more unified protocol. My question to you is something slightly different in terms of we're talking about different durations, and I know the ICECAP trial they have as low as 6 hours if the data supports it to cool for less time. But you've shown a lot of compelling data that cooling for longer is necessary or has better outcomes. Can you talk to a little bit about, a lot of these patients are very sick. We start talking about goals of care. How have you tackled that situation when you know that cooling might be helpful and we don't even, how do you address goals of care?
Yeah. So first, great question, and I'll be the first to admit this is hard. This is you've hit upon a very hard issue, and it's very, very sort of patient and family specific. So a couple of thoughts. First, the easy ones. The first thing is I'm sure you're all this way too. Of course, it's very important to be very cautious with overarching, like they will not survive, they will survive, but you guys know this. I think it's always reasonable to really lay the groundwork for expectations and say to family, look, your loved one's very sick. Their chance of surviving, is not certain right now. And we're going to know more in the next day or two. I think frequent dosing of expectation setting is really helpful. I'm sure you guys agree. You don't want on day 3, oh my God, you never said they were going to die. So I think early on saying, look, your loved one's very sick, and we're going to do our best, but we're in a tough spot here. They need to hear that, and that doesn't mean the patient's going to die. That means they need to know it's exactly what you said. Things are tough. It's also important to know that the brain injury after cardiac arrest is a long process, days and days. And I've seen many people recover despite being comatose for 4 or 5 days. And indeed, there's some good data published from our group and others on this. So it's really important not to be premature with these patients. Now, you're critical care docs, you can use your judgment. Certainly, there's some people who that rule does not apply to. If a patient is moribund, and you know what I mean, escalating pressors, multi-organ failure, DIC, that I'm not saying, wait 3 or 4 days. Right? I mean, there are cases where it's like, look, it's obvious this patient is dying, and they're going to die within the next 24 to 48 hours, and we really don't want to code them again because this is not going to work. But for the garden variety patient whose hemodynamics are reasonably stable, whose organ injury is not so bad, but the main lesion is they're not waking up, I think it's really important to give them some time. And it may take 2 or 3 or 4 days for them to show which direction they're heading. Indeed, protocols are being developed around the country that sort of stipulate an MRI on day 5 for many of these patients, because it's hard to know. I'm not saying we should necessarily do it. That's not been clinically proven as an established thing. But the point there is that many people are comatose on day 5, and we're like, I don't know, are they going to get better? Are they not? What do we do? It's hard. And those are the toughest patients. The moribund ones are easy. Goals of care, totally appropriate, probably not appropriate for the study. Indeed, in the ICECAP study, one of the criteria is a clinician has to have it's a loose criteria, but they have to have a reasonable conviction that this patient will survive 5 days. Now, how do you define that? Impossible to define. But again, it's one of those things that you sort of know it. Like if they're dying, they're dying. So the 4 pressors, creatinines bumped to 5, showing signs now of shock liver, DIC, whatever. That patient's not surviving 5 days. Like, let's just be honest about that. So that's not an ICECAP appropriate patient. But there are those who are less injured. So this is a long way of saying it's a tough thing. I think that if a patient's an ICECAP candidate, of course, you're going to be picking ones who are maybe not quite as sick. And this is why, by the way, this is really for out of hospital arrest. As you know, the arrests you have in your ICU, these are like a different phenotype, right? The ICU arrests are people who are already critically ill. They're in the hospital and they're in the ICU for a reason. And they're getting worse. And they're going to arrest because they're getting worse. Those patients are not, those are difficult study protoplasm, A. And B, those are patients who have a very high mortality rate. Maybe not initially, maybe because you're a great resuscitologist, you'll get them back initially. But the survival rate for folks who get ROSC in the ICU from an ICU-based arrest is very low and very patient-specific. So that wasn't a total answer to your question, but I want to just put some thoughts on the table about this. But the most important thing is this is hard and very patient-specific.
Hey, Nick, thanks again. That was a great talk.
Yeah, we'll get your question to you. Yeah, go for it, Cappy.
You can see me. And I really appreciate you sort of raising the philosophical idea that when you have little to lose and only things to gain, why not, go for it? I think we've all seen sort of a gradual sort of loss of enthusiasm for this, both in the ER and in the ICU. And I'm wondering, I remember when cooling was just starting to be talked about, even though it was a little late after the study. It took 8 years or so for the 2002 papers to really hit New York City. I remember as a resident, there was a lot of enthusiasm about the rapidity of cooling, and how do we, I guess, as now that you're in charge of the ED, how do we sort of reinvigorate the enthusiasm for getting people to goal very quickly? Because I think the animal literature supports that even short delays in cooling result in differences in tissue injury. So I'm wondering how we used to do ice cold saline and throwing bags of ice on people before there was an Arctic sun. And I think that's all kind of loosened up quite a bit. So I wonder how you think about that.
It was a very sophisticated set of questions. I love that topic. I wish we had another hour to grab coffee and talk all about it. Yes. So this is something we'll need to work on, and I'll work with our EM critical care colleagues on tightening this up as best we can, given all of our constraints. But yes, what is clear, and I'll agree with you, the data are very clear that time to cooling matters a lot. And other objections have been raised about some of these studies that they got to it so late. When you look in this animal studies, the trigger of physiologic injury can be measured within minutes. And this is well known. Those who study IR injury, ischemic reperfusion injury, and myocardium and other things, it kicks in right away. So just to get geeky for a moment, cytochrome C release from the mitochondria, a marker of imminent apoptosis, mitochondrial dysfunction, is literally within minutes of reperfusion. So if you're starting cooling 3 hours later, it's sort of like, the cows left the barn, if you will. So yeah, so we need to work on this. And in ICECAP, indeed, you have to get patients to goal temperature by 4 hours to be enrolled. And that is in part because they want to avoid that concern. If they get a null study, they don't want it to be because people are cooled too late. So we're going to have to work on this. And it ain't easy. It is not easy. So it will require some vigilance. Now, I will say that we are about to go live this spring, summer, not immediately, but soon, with a new resuscitation area in the ED. It's being renovated right now. We're going to have a new resus area with this new EM critical care residency. So we're moving in a direction of better EM critical care. That will be helpful, although it's not the whole story. So we'll have to work on that. But yes, time to cooling, very important. And indeed, one final point that I'll get to now, to underscore your point, There are studies showing that if you cool during CPR, it's hugely beneficial. And there's some crazy studies out of Europe where they use this special nasal cooling device, which could rapidly cool the brain during active CPR in the field. And it showed a lot of promise. And I think we'll be hearing more about that. So yeah, time to cooling, very important. Now, to the lack of enthusiasm thing, I think it is very important for this crowd to have the following take-home lesson. 33 versus 36, reasonable people could disagree. Like I may sound like a zealot for 33. Don't misinterpret. I'm a zealot for individualized patient care, and I think some people may, but this is still an open controversy. I do think not doing anything is inappropriate based on the data. You have to do something. So if you make an argument for a specific patient not to get 33, I would never lose my S over that. But to say, oh, we're not going to do anything, I've seen it time and time again. People spike, they have worse outcomes. So if you want to do 36, okay. If you want to even do 37, okay. But I don't know, do we have the Arctic Suns? Is that the device we use at Sinai? Okay. Yeah, you got to still slap on the Arctic Sun and set it to something, because that device is very effective at fever prevention. And I'll tell you right now, neurogenic fevers, rectal Tylenol, not sufficient. Just not going to cut it. I'm sorry, Nana, your question.
No, I'm so glad you brought that up, because one size doesn't fit all. And precision TTM and high quality TTM means that you're going to monitor someone's temperature continuously, that you're going to use high fidelity devices. For surface cooling, we end up using the Arctic Sun, but having a protocol and doing something. And I almost wonder if fever is that biomarker of a lot of other things that we're not able to measure for secondary neurological injury, whether it's evolving edema, whether it's this, massive cytokine release that's happening, this inflammatory cascade that's set into motion that leads to eventual establishing of hypoxic ischemic brain injury and other systemic injury. So fever in some ways might actually be a biomarker of worsening injury and then perpetuate more injury. And by the time somebody gets a fever, then it's so much harder to control and bring them back, to whatever temperature. Couldn't agree more. It doesn't matter so much what kind of temperature target you're choosing. That's one piece. However, something that I don't know if we're going to have time for this, and we may have to continue the conversation further. But from a cultural perspective, we were so quick as a field to abandon TTM, and adopting it took so long, and we made all these gains, but abandoning it was so much easier for people to say, oh, now we don't need to do anything. However, now that we have this really strong culture of EM, critical care collaboration, how do we use that as an impetus to not only continue participating in IceCap and SirenNet, but just really close collaboration on how we translate evidence, whether it's TTM, whether it's other things, but how do we make sure that we don't abandon good practices?
Yeah, I love where you're going with that, and I think we're gonna have more meetings to discuss these topics. But yes, it is a truism in life that if people have an excuse to do less work, they will do less work. So that's why adoption of a new thing is hard. Abandonment if it's work. So that's an unfortunate reality of being humans in a very work-stressed environment. It is what it is. But it's unfortunate because in this situation, it means that we're not being as thoughtful about appropriate decision making. Now we'll have to continue this conversation over coffee, but I really do look forward to working with ICCM and all of you. And because yes, not just for cardiac arrest, there are many areas that we can make improvements and remain critically care excellent at Sinai.
Ben, thank you so much. It was great to see you.
Wonderful, guys. Great. And so grateful for this invite. And I look forward to meeting many of you in person over coming months.
See you soon, Ben.
Okay. Bye-bye.